just want to introduce Catherine Nix. Catherine is a consultant in intensive care medicine in University Hospital Limerick. She's the chair of the Joint Faculty of Intensive Care Medicine Ireland POCUS Committee. She has trained and done fellowships in both Ireland and in Toronto. And she has organized and taught on many ultrasound conferences. So without further ado, I'm going to give you... Oh. Catherine Nix.
Thanks, Nick. And that's a bit of Taylor. And it's a song called Everything Has Changed, because I think POCUS changes a lot of things. Especially, I've come to know Nick through the EGLS courses, and working with the guys, Lacto and Francois, who've set it up. They talk about how 25% of the time in the emergency room where they work in Montreal, it can change their management. So 75% of the time, the history and the exam are still key. However, 25% of the time, I think, is a good hit rate to have something change your management. So I agree with Peter that using ultrasound as an adjunct to your assessment is really important. So I hope these cases help convince you. This first one is a critical care case. It concerns a 32-year-old female. She was in a vehicle that hit a wall, so high velocity injury, GCS5 at the scene, and was brought in by ambulance to our emergency department. And she had multiple injuries. And amongst those injuries was a grade 2 splenic injury on her CT abdomen and pelvis. It was reported that she had a subcapsular splenic hematoma without evidence of active hemorrhage. What I found interesting was I got the verbal report because a number of us from the ICU team were down with the emergency team. So what I found interesting was that the radiologist commented that, you know, the IVC looked really flat on CT, and he said this is a hypovolemic scan. The bowel is starting to look ischemic already. And I remember thinking, well, we actually have fluid resuscitated quite a bit since she's come back from scan, and that was on the basis of a POCUS view of the IVC. So we gave about 4 liters, and the hemodynamics really improved. We gave blood. There were a number of us resuscitating, and we managed her as per ATLS principles. And we called the surgeons, and she was a transient responder. So the surgeon said to us, well, maybe the splenic injury should be managed conservatively. And I was on for ICU that night, and I was thinking, this is a high velocity injury. We want to be really sure there isn't much active hemorrhage. So a little later, we agreed, the surgeon and I, that, you know, we'd go away, let people catch up with the fluid resuscitation, the blood products, and we'd come back and see, you know, had she really responded to all the resuscitation that was going on. And I put on the probe and I said, look, you know, there's much more fluid now around the spleen. And moving along to the next part of the FAST scan, this is a view of the liver, and you can see here there's at least a centimetre there, and it's right around the liver. So this is a curvilinear probe. I usually don't use a curvilinear probe, and I don't often do FAST scans, but there was no doubt here as to the amount of fluid in the abdomen. So then I had a look at the pelvis, and again, you can see a large amount of fluid here in the pelvis, and another view here. Okay, and there was no doubt in my mind that this woman had a lot of free fluid, and I was worried that maybe that splenic hematoma was actually bleeding, and the reason we hadn't seen it on the CT was because she'd been so hypovolemic at that time, shortly after she'd come in. So this was the cardiac probe, because I did a lung scan as well at the time because she had some lung injuries, and also having a look here at the IVC. So this video is looping. It's a subcostal view, and if you focus your eye on this part of the scan, that's the aorta there. But as I'm scanning through here, you'll start to see the right atrium coming in here. And you see that despite our fluid resuscitation, we didn't have a nice chunky IVC. So the decision was made to do an emergency laparotomy, and actually it was my colleague who was on for the ICU. I was actually on for theatre. So during the emergency laparotomy, we were surprised to find that it was actually a complete transection of the duodenum that she had, in addition to other bowel injuries secondary to the shearing forces during that high velocity impact. So the fluid was actually enteric contents, and there wasn't much active splenic bleeding. So for me, the POCUS was a game changer in terms of, finding out what that free fluid was in the abdomen and helping push for the definitive treatment. So the next case then concerns a perioperative POCUS story. And I like telling these because often, anaesthetists say to me, well, will the POCUS change my management? This patient needs an anaesthetic. And in this case, it did. So this is a case of an 80-year-old female listed for an open reduction and internal fixation of a periprosthetic fracture. She'd fallen about 2 days prior to me being told about her, and she wasn't sure why she fell. She wasn't able to lie flat. And the nurses told me this when I got onto the ward. And she told me herself. And also she'd history of bilateral pedal edema at the end of the day, and she slept on pillows, and she wasn't very mobile, but cognitively she was great. And she said, look, I just want to get home. Like, I live near my family. I want to keep walking. Even if this surgery is high risk, I want to take that risk. I want to maintain the quality of life that I have. I had a look through the notes, and I noticed that ever since she'd come in, they'd been looking to get an echo done, but of course it hadn't been done, as is often the case. And the orthopedic surgeons were really apologetic, so I thought, well, you know what, I'll take the handheld and I'll go up and have a look. And I did what I call a FUSIC Heart Scan. So a plaques view, a PSAX, apical 4-chamber, subcostal, and I added in some lung windows as well. And this is the scan. Now you'll see here that I would like to have better images, but I should have done this presentation before today, but I couldn't get the scans off the VScan machine, so I decided I'd take a video of it and put it up here. And this is essentially what I did. I brought these videos to the Department of Cardiology. So you can see the aortic valve here. This is a plaques view, okay, and you can see the mitral valve here. And you can see the right ventricular outflow tract here. And this was my attempt at a parasternal short axis view. And I didn't think the function of this ventricle was great. And that was sort of in keeping with the story that I'd heard. And I was a bit worried about that aortic valve because, she may have had a blackout. So I brought these pictures up and discussed them in the Department of Cardiology. And, they felt they'd seen worse cardiac function, but they see a lot of bad cardiac function, and they admitted that they agreed with me that the function wasn't, as good as you might hope when you're about to give someone an anesthetic. They didn't think that there was aortic stenosis there. And I know these images may not look great, but when they had a close look at them on the machine, they were fairly happy to reassure me that there was some ventricular function, that this wasn't a significant stenotic valve. So I thought about what I'd do for this lady, and I felt, well, she'd likely a calcified aortic valve. Her LV function was reduced, but not terrible. So I decided I'd put in an awake central line and an arc line before giving a GA, because obviously this lady had to lie flat to have her hip fixed. But I decided I wasn't going to do a spinal. This was a periprosthetic fracture. So we're going to be at least 2.5 to 3 hours getting it fixed, lying flat. And I felt, given the fact that I was pretty confident. I'd had a second pair of eyes on the scan that the function was reduced. I wanted to be able to give inotropes after giving a GA, which is essentially a negative inotrope. And I organized a high dependency bed post-op, and she did well. I just want to thank Nick for the time to present here today, and also to lots of my colleagues in Ireland who, even though I use quite a basic level of scanning, they've allowed me to communicate my enthusiasm, not just to the anaesthesia community, but the critical care and EM community as well. And I'm noticing now that the EM community in Ireland is really embracing this, which is great. And I'd like to thank as well the companies that have supported us with devices in the hospital I work in. Back to you, Nick.
Thank you very much for that presentation, Catherine. It really gives us a really broad scope here, because the perioperative ultrasound, use of ultrasound, is not really something that is really talked about, and it's fortunate that we are having the CAI Congress next week, and there's a whole session about perioperative ultrasound. So yeah. That's great. I just wanted to ask you, I suppose, about the use of ultrasound before you give anesthesia. Do you use it very often?
So I don't, and then when you want to use it, it can be quite intimidating if you don't do it often. So that's where I'm really delighted that there's some critical care practice in my practice, because I find I'm getting out the scanner multiple times during the week that I'm covering the critical care unit. And then a whole week will go by where I'm administering anesthesia, and many of the operations are planned. So many of the investigations are already done. So the questions are answered. But for a case like that where the questions aren't answered, then it's really useful to have that skill from ICU. And we often talk in ICU about how transferable the skills are from anesthesia, the airway management, for example, to the ICU environment. But this is one where the skill is transferable from the ICU environment to the theatre.
Thank you very much, Catherine. That's great. Now, just one other thing as well. With the eFAST that you did, what do you think? Like, do you use the abdominal probe, the echo probe, the phased array probe? I'm sorry. Or do you think you can use any of them really?
So I think the abdominal probe gives far better pictures, and probably the EM people on the panel here can attest to that. Just get a beautiful view of the architecture of the liver, and I see there that Peter Weinersheimer, he could see the subcapsular blood in one of those images that I put up, and I'm not used to looking at fast scans. I just simply appreciated that there was a lot of fluid in the abdomen, despite the CT scan telling us that there wasn't that much. I think the abdominal probe is probably best, and that's why all the teaching modules use the abdominal probe. But generally speaking, your critical care specialist will have a phased array probe in their hand, and certainly depending on the handheld you use, if it's a dual probe handheld, it'll often be a phased array and a linear that's on it. So I think it's good to be familiar with the pictures from different types of probes and to know how to use them. And some people say to me, oh, this is terrible, we should have the same machine in every room. And I think, no, we should have different machines, because then the trainees will leave, and no matter where they have to work, they'll know how to use the machine.
Yeah, that's a great thought, because that's exactly how I would have expected that to be. If I had trainees, I would like to give them all kinds of machines, so wherever they go, they will be able to scan, whether it's a GE, Sonosite, Mindray, whatever, that
Sonari.
Yeah, exactly.
How to get them all in.
Exactly. Yeah. So they should be able to scan, like, wherever they go, with whatever machine, as long as they know how to switch it on, and that's really a key point, I think. It's just to get comfortable with the machines that you work with, and that they are able to scan, wherever and in whatever conditions, rain or shine even.
I'll jump in and make a quick comment that any machine is better than no machine, and any transducer is better than no transducer. So there's always the intent to optimize transducer for different image acquisitions. But as you said, that you have a V-scan and you have two choices, and so they're perfect, because if you need to scan, you grab the one that works the best and you get the images and you take care of your patients. So off you go.
Thank you very much.